Don't let my residents ever hear this.
It gets your mojo going.
It does. It's fun.
Probably be big rimping.
It's a safe place here. We're in the trust tree. I use inhaled sildenafil.
We're smoking like a rock beer.
Yes, we are.
Dangerously drinkable.
Actually, lucitropy is a thing.
So guys, thanks for coming. We have a nice ultrasound hot topic for today. It's going to be a 30-minute lecture. We're going to break it up into 2 parts. In advance, I apologize if I stumble over some words. I've got some really bad cotton mouth going on right now, and I've been NPO for the last 12 hours. But we should be able to get through it. So today we're going to talk about TEE and cardiac arrest. And really the goals of this lecture are to make you familiar with the concept of using a TEE in arrest and to kind of inspire you to feel comfortable doing it. And it's going to be a lecture in 2 parts. Part 1, we're going to call the birds and the bees of TEE. I know you guys have been doing a lot of transthoracic with your arrests. You've heard that some probes have been going down throats. You might be getting a little curious, wondering about the facts of TEE and what you can do with a transesophageal echo during a resuscitation. And so this is kind of what to expect. You might be a little fearful, intimidated, wondering, how do I know if it's the right patient for me? What if I go down the wrong hole? We're going to talk about some of these things today to help you feel more comfortable with this process. And then part 2 is called Deep Throating the Black Mamba. We're going to do a live demonstration with the goal being to make you feel comfortable that if we can do this on a live Brian, you should be able to do this on your dead patient when they come in to assist you in making good decisions. So why are we doing this? The reality of resuscitation right now is that we have standard ACLS, and that relies on a handful of techniques. So we use compressions. They're in a specific location. We use epinephrine. 3-lead rhythm checks for identification of, 3-lead EKGs for rhythm identification, and we do pulse checks, okay? Now, each of these things has their problems. Compressions, we don't know why they work, which means we don't know how to make them better. Epinephrine, I don't really have anything really bad to say about epinephrine, but if you look at the H's and T's of reversible causes of arrest, epinephrine's not a cure for any of them. It's a support drug. And so is it really a panacea? 3-lead identification is unreliable, pulse checks are unreliable. So there should be something better than this. And we use TTE guidance, right? Is that better? So in 2015, the American Heart Association updated their ACLS recommendations to specifically address the role of ultrasound at ACLS. And I cannot think of a more lukewarm endorsement of ultrasound than their statement here. If a qualified sonographer is present, you might consider using ultrasound as long as you don't get in the way, and it might not even be that useful. But it's level of evidence C, and it's not really based on data, and it's really just kind of their opinion. So you guys have become TTE rock stars with the way you approach resuscitation. You're getting images like this in peri-arrest periods, identifying dissections, tamponade physiology, biventricular heart failure, PEs, a lot of great diagnoses that you're picking up, but TTE has its limitations. It can be time consuming. You've got to get the gel prepped. You have to get in position. You're waiting for that pulse check. And while you're doing that, you can't be doing other procedures. You can't be working on vascular access or airway or interpreting a VBG or the patient's history. You're right in the middle of the resuscitation where there are pads, where the thumper's going, and so it's a difficult position to be in. It has the potential to lengthen pulse checks, although we don't have any data on this. It just makes sense. If you're in there digging for a view, there's a good chance you're going to go beyond the 10 seconds that's recommended to maintain a good perfusing compression. And the images can be difficult to interpret. I think everybody's had the experience of getting ready for that pulse check. They're psyched to get into the subxiphoid view, and this is what you see. And you're going, is that liver? Is that bowel? What am I shooting through there? Do I really see any cardiac tissue? Is it moving? Can I be certain there's no activity at this point? And then 10 seconds is up, and you're back on the chest, and it's 2 more minutes of compressions before you can take another look to try to make a diagnosis that might help in the resuscitation. And that's kind of the reality of it. And I think TEE has a lot of upsides that turn some of those disadvantages into a more advantageous approach. You get to put the probe in and leave it, which means that you can be doing other procedures and you can get high quality images while CPR is ongoing. And it has the potential to shorten pulse checks, although we don't have any data on this either. So you can be a TTE rock star again. And if well, TEE Rockstar at this point. And if what you're doing is taking a patient that comes in from the field and undifferentiated arrest, and within the first 2 minutes of compressions before you do a pulse check, you're able to put the probe down, and so that when you look for the first time, you see this. This is a mid-esophageal 4-chamber view. This is the first thing you're going to see when you get the probe down in appropriate orientation. And that's ventricular fibrillation. You know exactly what to do as soon as you see it. You're back on the chest in 3 seconds at this point because you've had the chance to evaluate it as soon as compressions are stopped. You're charging for a shock, it's delivered, and you have the opportunity to see the direct effect of your shock without having to wait an excessive period of time during the next pulse check. And this kind of puts you into a new category of rock star. You're a futuristic, resuscitative, alien rock star from another planet, and it's a whole new level of cool. I think this is really awesome, by the way. That's Jimmy Fair photoshopped as Ziggy Stardust for people that don't recognize it, which I think is really cool. So how do you know you're doing it right? Patient selection it's pretty easy. They have to be dead, medically dead. I wouldn't do this in trauma patients. You should have a definitive airway, which takes care of a lot of the wrong hole issue, but it also makes sense. You can't bag a patient that has a probe coming out of their mouth, so you should be intubating them and setting up appropriately for that to be able to access their esophagus. And for now, at least, we have 4 core faculty, well, I guess not really core, we have 3 core faculty that are comfortable doing this, and as a fellow, I feel pretty comfortable running the TEs and resuscitation. But Patrick, Mike, Jimmy, they should be there until we get more people up to speed on this, feeling competent using this technology, and then it'll be sort of open at that point. There are full guidelines for contraindications to TEE. Those are worth reviewing. They're not formally data-driven in the setting of arrest, per se. A lot of them are based on elective TEE, so the risk-benefit ratio there is going to be a little bit more difficult to tease out, but use good judgment, okay? You don't want to do this on somebody that had recently surgically operated on esophagus. You don't want to do it on somebody that has known disease that would contraindicate performing the TEE. And then finally, what will it look like? So the TEE gets a rap as being a really complicated procedure, but it's really simple. You have a transducer. That's that part right there on the bottom left, next to the word transducer. There's a knob, and there's a button, okay? I think you guys can handle this. So the knob directs the transducer in anteflexion, retroflexion, side to side. The button allows you to rotate the omniplane, and I think this is one of the big catch points that makes it difficult for people to access this technology. This is essentially what the omniplane does. When you're on the chest with a transthoracic probe, you rotate the probe to get into different axes, right? You go from a long axis to a short axis in the peristernal area. If you're apical, you'll go from an A4 to an A2 to an A3, and all you're doing is rotating the probe. You can't do that with a TEE probe. So it doesn't actually move to rotate its plane. The crystalline array is redirected in such a way that the vector you produce will be pushed in a new direction. And so at 0 degrees, which will be a neutral plane when you introduce the TEE, you'll essentially be parallel to the diaphragm, okay? You'll be spitting out in a plane that is very similar to the way you shoot in from an A4 view, all right? And if you rotate to 90 degrees, then you'll see that rotation there. Now you're going up and down, and you're getting that more sagittal plane at that point. You're perpendicular to the diaphragm. And so if you use the other motions, flexing to the left or right, rotating the probe, you can redirect that to create a wide variety of perspectives and images that can allow you to make really nuanced discussion and diagnoses in your arrest patient. The other thing you can do is advance and withdraw the probe to create subtle changes in the way the image appears. Just like you would kind of adjust your A4 slightly anterior to bring the LVOT in view on a transthoracic view, you can withdraw the TEE probe slightly to get a more anterior view and bring the LVOT in view on a mid-esophageal window. So these are the views that you need, and Jimmy Fair is going to talk to you about these while I get set up for part 2.
Okay, thanks, Brian. He is going to be busy numbing up his throat because despite what you've heard about him, he does have a gag reflex. So these 4 views are pretty much all we need to effectively guide a cardiac arrest resuscitation. Of course, just like there are a bunch of different views in transthoracic, there are a bunch of different views we could talk about in transesophageal echocardiography, but these are the 4 we would like you to know and be familiar with in order to effectively guide a cardiac arrest resuscitation. So we'll start off with the mid-esophageal 4-chamber. So this is a view you're familiar with if you're standing on your head. So everybody stand on your head right now, or imagine that, and think, what view does this look like? Anybody? Yeah, it's an apical 4, just upside down. These are all the same structures that you're used to seeing in an apical 4. Think of the think of the probe as sitting behind the heart in the esophagus. So the first structure that you're going to notice is the left atrium, because the left atrium is going to be closest to the probe. So if we follow the left atrium through the mitral valve here, that is the left ventricle. And then, of course, that makes us the right ventricle and right atrium. All images that you're familiar with looking at normally. Notice that our multiplane here is at 0 degrees, so we're relatively parallel to the diaphragm. If we stay in that location and just move the multiplane to more around the 120 degree ballpark, then all we've done is rotated, instead of being parallel with the diaphragm, we've rotated so that we're now in more of a sagittal plane, just a little beyond sagittal. And then that's giving us this view, which, what does this look like? Yeah, it looks like a parasternal long, right? We're seeing all the same structures that you're used to seeing. We're seeing aortic valve here, mitral valve here. Of course, the left atrium is closest to the probe because that's where the probe's sitting. And then we have our right ventricle over here with our aortic outflow. We're used to seeing this in transthoracic from this angle, right? Your probe's up on the chest and shooting down, and the left atrium is the deeper structure. We're just seeing that in a mirror image, essentially. This is a midesophageal long axis when compressions are ongoing. This view can be useful for seeing if valves are opening effectively with compressions, and then evaluating those structures during pulse checks as well. Notice in this image we also see a hyperechoic wire here, and this is somebody that's getting cannulated for ECMO, which is can also be useful for confirming procedure guidance here. All right, this is the bicaval view. Think of this as the analogous view to evaluating the IVC when you're doing transthoracic. This can be a good view for evaluating volume status. Again, we're shooting through the left atrium because that's closest to the probe, and then we're seeing right atrium over here. And instead of just seeing IVC, we're seeing IVC communicating into the SVC. This view in particular is useful for procedure guidance because we're going to be able to visualize structures that are in the venous side of the heart. So when we're doing ECMO cannulations, it's important to visualize that wire first in the venous side of the heart before we dilate up to much larger cannulas and create large holes in vessels. This is our, if we were to swing completely over to the left, we can see the descending thoracic aorta. And we include this, which is just this cross-sectional view of the aorta here. Notice we're at 0 degrees, so you'd expect it to be parallel to the diaphragm as we peer over into the left side of the chest to look at that aorta. And again, this is going to be very useful for procedure guidance when we're trying to verify that a wire is in the arterial side before we cannulate what we think is the artery up to a much larger sized cannula. All right, and so this is some of the examples of pathology that you might see. What would you guys say about this image as if you were seeing it in a transthoracic echocardiography? Yeah, so I'm hearing there's wall motion abnormality. Certainly the base seems to be squeezing, but the apex seems akinetic, right? So this would make us worry about an LAD occlusion in the right context, and certainly someone with this severely decreased of an EF might be somebody who arrests, right? What do you guys think about the pathology in this image? Yeah, one side of the heart's squeezing, but the other side isn't. The right side of the heart isn't squeezing. This is a case of actually RV myocardial infarction, a right-sided infarction. So RV dilation and lack of contractility is not always PE. It's sometimes other pathology. Right. All right, and here's another example of severely decreased ejection fraction in the left ventricle. How we doing, Brian?
We're doing good. I'm going to see if I can get the thing down my throat.
All right. That brings us to part 2. Brian's going to esophageally intubate himself.
Watch this part. Said it's better if you don't watch this part. So if you guys see me crying during this, I'm not actually crying. Those are tears of joy for your educational experience. And if you see me retching, I'm not really retching, that's just belly laughter. Having my insides tickled.
So
Wow, quite block.
I think you have to put on the floor.
This will make me more comfortable. If you want to get on this to help assist with the retro inflation, throw it over that guy.
Should I use my other hand? Or your gloves? Okay. Oh, I'm sorry.
Here, take that all the way down.
Yep.
Sweet.
All right. So, Dr. Morrissey, one of the cardiac anesthesiologists, is going to help out with driving while we demonstrate this. All right, so you notice that the very first image that you saw was that mid-esophageal forechamber, which is analogous to the apical forechamber. So without any manipulation of the probe, that's the image you get as your first image, and you can see how useful that would be in a cardiac arrest scenario, right? You're seeing all the structures of the heart quite clearly right off the bat. Sometimes there's going to be some air bubbles, which is creating the artifact on the right side of the screen, which just moving the probe back and forth up and down a little bit often will get rid of those air bubbles. Or compressions. And so as you can imagine, the heart doesn't project out completely perpendicular to the diaphragm. It sits with the apex directed a little bit down and towards the left. So it takes a little bit of rotating the probe towards the left and what we call retroflexion to get, which is going counterclockwise on the big knob, in order to get the true long axis of the ventricles there.
Do you want me to?
Perfect. So see how we're I'm going to point out on the screen just a little bit here. So as the if the probe comes a bit more superior, then we'll start to see the left ventricular outflow tract, and then if we go down deeper, we'll lose that left ventricular outflow tract and get this image, which is our true mid-esophageal forechamber. So if she stays in that location, and then we just adjust the omniplane, which we're going to see move up to the left side of the screen here, Then we're going to move into a long axis view. And so again, think of this as similar to your parasternal long axis in that you're seeing all the same structures, only from a different angle. And so as we see here, we're noticing the mitral valve still in view at the top of the screen because, again, we're peering through the left atrium here. And then off to the right side of the screen, we're seeing that aortic valve pop into view. And then right ventricle over here, of course, left ventricle, the larger structure you're seeing there. So again, this is going to be useful in being able to evaluate your mitral and aortic valves well, and also during compressions to see where you're compressing maximally on the chest, whether you're getting the ventricles to compress and causing that aortic valve to open up and produce blood flow forward, or whether we're just kind of mashing on the aorta and not really pushing any blood flow forward. Now, if we want to evaluate volume status or guide procedures, we can swing over to what's called the bicaval view. Generally, that's going to be with an omniplane in the ballpark of 90 degrees. So Dr. Morrissey is going to decrease that omniplane a bit, and then we're just going to swing the probe over towards the right side. And again, the left atrium is always at the top of the screen when we're in this mid-esophageal location. So that's your orientation point. Then we're seeing the interatrial septum flopping back and forth here a little bit. So that makes this the right atrium. Off to the left side of the screen, we're going to see a little bit of IVC coming into view. And off to the right side of the screen, we're going to see a little bit of the superior vena cava coming into view. So if we see a wire in the right atrium, that means we've cannulated a vein in the femoral region, and that it would be okay to dilate that up and know that it's a venous structure that we're dilating up. And then if we wanted to try and identify a wire on the arterial side of the heart, we would simply move our omniplane back down to 0, swing over towards Brian's left side, and then we're seeing up at the top of the screen an aorta here in cross section, and then we can decrease our depth a bit if we want to optimize our view of that. So you can see if we have a wire running through there, it'd be quite easy to see. And then if we wanted to move to a long axis of the aorta, then all we'd have to do is rotate our multiplane up to 90 degrees, and then we'd see that in more of a long axis. Okay. Thanks, Dr. Morrissey. We've gone through all the views. What questions do you guys have?
What's the most useful of all these planes? I mean, I think for us, people maybe do this just beginning, just 4-chamber.
Yeah.
Initially, when you drop it down, and then rotate in order to get your like short axis. You can run a whole code in 4-chamber.
Yeah.
You can run the whole code in 4-chamber. Really just 4-chamber.
So if you had one view to help you during a resuscitation, it would be the mid-esophageal 4-chamber, because you can see all the structures. You could see the right heart if there were right heart failure. You can see the left heart if there were left heart failure. And you can see what the heart is doing immediately during your pulse checks. And so let's say you don't work at an institution like ours where you have 20 or 30 doctors helping out with a code, then then you could literally place this, hang it on an IV pole, and leave it. And then you've got real-time feedback on what the heart's doing immediately during your pulse checks. I think Erica had a question, and then J. Ray.
How you hold it, and you suggest an IV pole?
Yeah, you could literally, so the anesthesiologist commonly, they just have a loop on their TEE, which they'll hang on an IV pole basically, and manipulate as they need to, but if they don't need to, it's just hanging there with visualization of the heart.
How worried do we have to be about esophageal perforation, and what ways should we avoid that?
If it's not going easily, don't push hard.
So one thing too is if you're inserting the probe, the best time to do that is probably not during compressions and maybe during a pulse check if possible. That's kind of how we have done it.
Positioning the head so that they're more of a sniffing position is useful, and bringing the jaw forward, like you're doing a jaw thrust, will also help make the esophagus more accessible.
And when you're in there, just be gentle with it. Don't just like force it around.
Yeah, the risk published in the literature is 0.03% of esophageal injury, which is quite low, but that's not in cardiac arrest patients, so we don't know the exact risk in cardiac arrest population.
For giggles, can we get a right heart view and do a leg raise and maybe have see if we, I don't know, I just want to see if pushing the dynamic. Oh yeah. Leg down.
That's his coronary sinus up there.
Legs up.
All right, can we get a hand for Brian, everybody?
The second time is not as bad.
If anyone wants to talk about doing an ultrasound fellowship,